All right, welcome everybody. It's March 20th, Friday, and we have another Florida EMS webinar, which is part of the NAMSP Florida chapter. Hopefully, we'll be seeing some of you in Washington, D.C. this week for EMS on the Hill. And it's going to be a great time this week. And for those of you who are joining us for the first time, welcome. We do this every Friday from 11 to 11:30 Eastern time, and then we roll right into Dr. Pepe's Evils webinar, which I'll put the link at the very end. Today we have some great friends, actually our co-host Tanner Smida and our two great friends, Josh Kimbrell and Judah Kreinbrook, which by the way, we all met at NAMSP. This is how this all got started. And then these studies start to percolate and you start to work together in collaboration with other people. And this is exactly what happened today. And this paper that you'll see today is going to blow your mind because we all think we do this one thing particularly well when it turns out we don't. The data are pretty shocking, if you will. And so without me bearing, I guess I don't want to bear the headline here, but let me turn it over to Tanner, Josh, and Judah. Welcome to you all. Thanks for joining us and take it away, my friends.
All right, everyone able to see my slides?
Yeah.
All right. So I'm going to get started. We're gonna go through a little bit of background, talk about the methods of this study, go through some ECGs together before getting to the results, and maybe get some interaction from the crowd. So starting out, what do we know about transcutaneous pacing? From some previous work that's been presented on this webinar, we know that this is certainly an uncommon procedure. Our group did a study looking at the ESO Data Collaborative, and of about 30 million EMS encounters that we assessed, only about 13,000 of those encounters included an attempt to perform transcutaneous pacing. This therapy has been studied repeatedly in the context of randomized controlled trials for the treatment of bradyasystolic out-of-hospital cardiac arrest, and we know that it is not helpful for that condition. And so current guidelines, the American Heart Association, European Resuscitation Council, etc., they tell us that now we are only supposed to be applying this therapy to patients who have a pulse, they have to have bradycardia, and hemodynamic instability that we believe is rate related. But we don't really have a lot of data on the effectiveness of this therapy in that population. Um, we know that they have bad outcomes. That's one thing that we can say. So in our ESO study, we found that overall, for patients who receive a transcutaneous pacing attempt in the pre-hospital setting, overall mortality is about 60%. Even among those patients who do not sustain a cardiac arrest in the pre-hospital setting and make it to the hospital alive after a transcutaneous pacing attempt, still 1 in 3 are going to die prior to discharge. Perhaps even more relevant to kind of us in the pre-hospital setting, when you encounter that patient who is bradycardic, has hemodynamic instability, and you make the decision to put the pads on them, there's a 1 in 5 chance you're going to be doing CPR on that patient prior to hospital arrival, right? So that this therapy fails frequently. Now, I presented some of these data at the National Association of EMS Physicians annual meeting. I think it was back in 2023. And I walked down off the stage into the back of the room, and Josh grabbed me right at the back of the conference room and said, "I think I know one of the reasons why we are seeing such poor outcomes in this patient population." And he had noticed that in his role as a quality manager at an EMS agency, that when they actually went back and reviewed the monitor files for patients who received transcutaneous pacing, they observed the ECG characteristics that are associated with electrical capture, so that kind of wide bizarre QRS, the ST segment, the T wave. They were only seeing these hallmarks of electrical capture in the minority of cases, right? So, and their conclusion from that study, which was published in Pre-Hospital Emergency Care, was that we are essentially not performing this procedure correctly in the pre-hospital setting, and we're not recognizing that we're not performing it correctly. But the criticism there was that, little over 20 patients, single EMS system, maybe it's a problem for that agency. Maybe it's a problem with the training of your medics. But over here, where the grass is always greener, I've been doing this for 20 years and I do it right every time. And I've never seen a patient not get capture, right? And so Josh and Judah, we put our heads together and decided this deserves some study. with a multi-center design, so we can bring in more agencies, more patients, perhaps establish that this is a widespread problem, and then also maybe do some additional investigation with a larger sample size into factors that are associated with actually achieving electrical capture during pacing. And so that's what we did. This paper was published in December of this year, just before Christmas, in the journal Resuscitation. And we'll put a link to that in the chat, and maybe even a PDF if we can put it in there. And so essentially what we did was we reached out to a number of different EMS agencies to try to get some collaborators. We ended up recruiting 4 different services, all capable of delivering advanced life support. All of them serve primarily rural areas. I won't disclose specifically what agencies collaborated with us, but we had 3 services in the Northeast and 1 in the Southwest United States. And so, and just to kind of speak a little bit about the logistics here, with the help of the West Virginia Clinical and Translational Science Institute, we got IRB approval, not only with our institution, but with external sites that had their own IRBs. We signed data use agreements with all of these sites. So they're the lawyers, our research manager, Catherine. There were a lot of people who were involved in making this a reality. And then once we got all the paperwork signed and we got everybody to agree to participate, there were essentially 3 stages of data collection. So the first stage was the contribution of data from the electronic health record for each individual EMS agency, right? So all the demographic variables, age and sex, and we collected whether paramedics documented electrical and mechanical capture, we collected drugs that were administered, all the stuff that you can get from an electronic health record. And then also we had participating agencies upload the cardiac monitor files associated with every case to a central REDCap repository. And then in doing that, we were able to do things like objectively determine when cardiac arrest occurred during these cases by looking at ECG and impedance data. And then again, we had ECG data from the time these monitors were turned on to the time they were turned off. And so we could, for every second that monitor was on the patient, we could look at the ECG and say, are we seeing the hallmarks associated with electrical capture? And so again, right, everybody used a different EHR software. We included both Zols and LifePack cases, right? So we certainly had increased generalizability in comparison to that original single center study. So here's just an example of some of the variables that we collected from the electronic health record. In terms of the variables that we collected from the monitor file, so I went through every file and abstracted things like when the pacer was turned on, the first current that was sustained for at least 60 seconds, which we called the set current. We looked at the maximum current that was achieved during the entire case, rate, again, the time at which CPR was initiated if the patient sustained a cardiac arrest, as well as vital signs. So we looked at pre and post systolic blood pressure, end-tidal CO2 values, etc. And then the final stage of this 3-stage data collection really focused on ascertaining whether or not electrical capture had occurred. And so Josh, Judah, and I essentially divided up these cases and reviewed them, scrolling through every second of monitor data and categorizing these patients as either having no electrical capture, intermittent capture, non-sustained capture, or sustained capture. Sustained capture really being what we want to see in these cases, right? So you have capture for 60 seconds, and then that capture is sustained until the end of the case or the pacer is turned off. And so an important point, right? This involves some element of interpretation, and we'll talk a little bit about inter-rater reliability later. But we made sure that for every case where we believed the electrical capture was observed at some point, all 3 of us looked at that case together and came to a consensus, right? Because at an individual level, there was some disagreement. Even, on our couches, right, with a cup of coffee as we're reviewing these cases, able to rewind and fast forward, there was still some disagreement. And you can only imagine the difficulty that translates to in the pre-hospital setting on the floor of someone's basement or in the back of a moving ambulance. And so Josh, I believe I'll turn it over to you, and we'll talk a little bit about what ECG characteristics we were actually looking for during this investigation.
Yeah, thank you, Tanner. So I would ask, as somebody that has been a paramedic educator during Zoom U and COVID, and now has been in medical school. I know what being on Zoom is like and how terrible it can be. But I'll ask that you like get your chat ready and your like keyboard ready because I want this to be interactive. So as we go through, I'm going to talk through some of these EKGs and ask what you guys think about these EKGs, and I want this to be really interactive. I think we think of this as like relatively simple, and I think it can be a little challenging. But I'm going to give you a little bit of primer with a couple slides first. So on this top rhythm that we see here from the ECG, what we see is a pacer spike. And then you have this wide arcing artifact. So Tom Boothloyd did a lot of the original work on this and has been on the papers that we've done on this so far. It's called this like a phantom complex. And you can actually see this swooping. There's no T wave, there's no structure, there's no QRS. And then there's this underlying rhythm. So you see this, like the arrows are pointing to these underlying bradycardic rhythms that make this really tough. So when we train our paramedics, we often tell them, hey, crank up the current until you see a wide and bizarre QRS. Well, there is a QRS. It's kind of wide. It's kind of bizarre, but this isn't electrical capture. You can see the same patient, they increase the current, and we see on the bottom, and you start to see this tall structured T wave. And sometimes it's not super easy unless you see it going from that phantom complex, that false capture, to that true electrical capture where we actually see a QRS with a discordant T wave. I think that's really important. And as we go forward, I want you to really humble, think about this humbly, like, hey, like we're sitting here in at least I'm in a very comfortable room with lots of natural light. I'm not in a basement sweating at 2 a.m. So it can be really hard. We can go to our next slide here. So this is just a graphical representation of false capture for A and true capture for B. So you'll notice as you crank up that current, this wide swooping artifact gets bigger. So let's say you're a paramedic and you have somebody that's bradycardic and they're hypotensive and you're convinced they're about to die. They're in that peri-arrest state. Your partner's doing 100,000 things at once, trying to get them oxygen and pressors and atropine and all these other things, trying to get a line on board. And you're trying to figure out the pacer that you haven't done in years. And now we're cranking up that current and it's getting really big. You can see just from the left to the right, you're like, oh, okay. Well, I remember my ACLS instructor like 12 years ago told me it would get really big. And you can do that. And you can also see this underlying bradycardic rhythm that's marked with the asterisk in this image that can also make it tricky. But the advantage to seeing the underlying rhythm is we know that you can't have a rhythm just show up in the absolute refractory period of EKG. So that's actually our clue. Hey, this is probably not capture. And you'll see that as we progress forward. And I know in the back of our mind, like there are a lot of people on the call that are probably thinking like, well, duh, you need to feel for a pulse. We're going to talk about that in a little bit, why that can be really challenging. Here at B, you can see there's actually a structured QRS. I know it looks weird. It still picks up some of that pacing artifact, but you can see a discordant T wave. This time it's going in the other direction, and some real structure, and there's no underlying rhythm marching through. Let's go to the next slide. So I want everyone to tell me, put in the chat, yes or no, for this is true capture. All right, that's really great. You guys are welcome to keep putting it in, but we have a resounding no so far. You're absolutely right. As you see here, you have this underlying rhythm that's marching through, and this kind of wide swooping artifact. I think the third one is that third one that he just went over with the mouse cursor is really characteristic of this. Next slide. So this is that same case. I'm not going to quiz you on it. This is the same one. So you see how it really changes morphology. You have the structure and you have this discordant T wave. This is what true capture looks like. Next slide. What do we think about this one? Yeah, I think this one's pretty easy. As you can see here, there's this wide swooping, again, artifact. There's no structure, there's no T wave. Next slide. This is the same case, ramped up the current. Now all of a sudden we have this tall, broad, discordant T wave. Next. What do we think about this one? All right, I agree. This is not capture. I think one really cool clue here is that exactly what we have here with the mouse cursor. You can see this underlying rhythm, like just in the middle of, I guess, what would be a T wave if this were capture. This is not capture. Next slide. What do we think about this one? So this one's a little bit trickier. Can you go back one, Tanner, and just show it for comparison? Like back one slide. Yeah. Or I think that's a forward one slide, right? Oh, yep. So this is 121. So this is the same one. And then, so these are actually the same case. And then if you go one forward, right? Yeah. So these are all that same case. So this is what that true electrical capture looks like when it's sustained. So this can be really tricky and something we should be really humble about. Next slide.
Yeah. And I'll also add here. So this is prior to them increasing the current and achieving electrical capture here. So you can see here what might be the T wave. This slide and this slide are the same couple seconds of ECG. This first one is lead 1, and the second one is lead 2. And so you can see lead also, looking at different leads or multiple leads on the same patient can help you identify true capture. And so if that's possible during a case, this might be something that you could do clinically. If you can print out a strip, if you can look at multiple leads on your monitor, that might be something that can help you distinguish between true and false capture.
Absolutely. Thank you, Tanner. What do we think about this one? All right, we got a yes. All right. Yeah, I like the way this T wave, it just looks really structured. And I don't know like an easy way to say that beyond just looking at this pattern recognition. Like it's not this swooping artifact that goes up and comes slowly back to baseline. This is something that's different, but something we always need to look for is sometimes that underlying rhythm can march through, but it doesn't really look like I don't think it's doing that here. Okay, next one. So I'm not going to quiz you on this one. I think this one's pretty straightforward. This is that false capture. You see that swooping artifact and that underlying rhythm marching through. Next one. Okay, what do we think about this one? Great job. So yeah, no, this is not. One thing that you can do on the LifePack, so this is a LifePack case. When it recognizes an underlying rhythm, the default is often in demand pacer mode. You can see the little triangle at that R wave, at the start of that R wave, that denotes the monitor is actually recognizing an underlying rhythm and it's delaying the next fire of the pacer. So that's another clue. Next one. And what do we think about this one? Okay, we've got one vote for no. We've got a yes question mark. Fusion, no. Tanner, is this the one where we have two EKGs of the same one, or is this just the isolated case? You're muted.
The actual case we do have multiple leads, but I didn't put any in this presentation. But this is true capture.
Yeah. Yeah. So I think it's so when we're talking about like fusion, that does happen sometimes, but I think when we have it happen, for it to happen exactly with the pacer each time, you know what? If our pacer is causing that heartbeat to happen at exactly the right time, maybe it's working. But yeah, we would call this true capture. And I think it's much easier when you see it go from false to true. It's a little bit harder when you just have a strip. So next slide. And this is a good example of false capture. Next one. And this is a true capture. I think this is actually the same case too, right? Yes, yeah. These are just using the Zoll case review, so it looks a little bit different. Okay, next one. Okay, and then I take these next two slides, right? So one thing that we wanted to do is we did a training. So Tanner, Judah, and I were the primary identifiers of electrical capture in this, and we wanted to make sure, like with all chart review studies, we weren't running into this trap of mismeasuring something that's really important. So we did a big training with Tom Boothaway and Brooks Walsh, who are authors on the paper and really experts in EKG review. They trained us on about 20 cases. We all came to agreement on those 20 cases. We separately adjudicated 20 cases, something like that, or 30 cases. And we did that against our gold standard expert reviewers, which was Tom and Brooks. And then we went through and looked. we found is that we nailed the ones that didn't have true capture, which is the vast majority of them, the false capture. And there was one where our experts said that there was non-sustained, said that there wasn't any non-sustained electrical capture, but we did. Let's go to the next slide here. And love Tom Boothaway to death. But we are convinced that this is non-sustained true electrical capture. So this is our one case that we had an error on. But what we did decide to do is we're going to come to consensus on every single case where one of us thought that there was true electrical capture, or if we didn't know, and then we divided the rest of them. Okay, next slide. Judah?
Thanks, Josh. So in total, we enrolled 387 cases. There were 53 cases that were missing waveform data. And then from the 334 that had the continuous ECG data available, we had exclusions that we set up before undertaking data collection, where if pacing was less than 60 seconds, if there was no pacing at any time, because we queried cases using two methods. We queried it both in the EHR, and in some sites, we were able to actually get the managers to query the software itself, right? So to look for TCP deployment. In some cases, the EHR might say TCP was used, but then you pull the file and you learn it actually wasn't. Maybe it was a data entry error on the EHR. So that's what you see there. And then there were two patients who were actually paced during cardiac arrest. Unknown, why that happened, but that wasn't, this study. We were looking at patients who didn't have or had some sort of intrinsic pulse. Looking at kind of the spread, you can see that for our primary, outcome of capture, we have 74.9% of patients had no electrical capture at all. 9% had intermittent capture. 6.4% had non-sustained electrical capture, which was defined as 60 seconds. And then 9.7%, only 29 patients had sustained electrical capture, which was 60 seconds having it. And then 90% of pace complexes from there on out had it. Importantly, if the intrinsic rate overtook the rate of the pacer, we didn't count that time, right? So this is just 90% of the paced complexes. Next slide. So next we wanted to see, okay, well, we've done what we wanted to do. We've got the capture rates. This will be helpful. But before we even started the study, we had an idea that this might occur, that current, is of interest, body weight's of interest, pre-TCP heart rate is of interest. And that came from the ESO study. So we sat down and we used a DAG, which I know Tanner has talked about ad nauseum. It's one of his favorite things in all of research, mine too. And we identified what variables would actually, impact what current was used. So we know monitor model could, impact that. If you use a Stryker, it goes up to a higher current. Zoll goes to a lower current. So it's not fair to compare this, the same monitors because, at least the manufacturer's claim is that 100 milliamps on both devices is different because they deliver a different waveform. Similarly, when you're looking at current, you want to look at body weight because we think that has some, impact. And looking at these associations, you see that when you adjust, you see that there's a 27% higher likelihood of adjusted odds of sustained electrical capture for every 10 milliamps that you crank the pacer up. Similarly, for body weight, and I believe this is every kilogram, when you look at body weight, it has an inverse association. You're 5% less likely to get sustained electrical capture. And then pre-TCP heart rate, which was taken just before TCP was initiated, we also see an inverse association. And so you ask yourself, why would a high heart rate have an inverse association with capture? Well, part of our thought here is those are patients who are sitting up right near those pacing thresholds, right? So these are patients who may actually have to be less sick when they're starting. And critically, we controlled for whether they had CPR prior because there were about 50% of our cohort were post-ROSC patients, right? So they had already had a cardiac arrest. And we also controlled for pre-pacing medications such as epinephrine, NORAD, et cetera. Next slide. So ultimately, we wanted to know, okay, electrical capture is great, but we all know we train paramedics, ACLS instructors, nationally teach this. you get electrical capture, you got to document mechanical capture. Well, 56.9% of all patients had a documented, we define it as a palpable pulse that matched the pacer rate. So the managers and, quality managers went into the charts and abstracted whether or not the crew had actually said that they had mechanical capture. Well, only 10% of those patients had sustained electrical capture. 72.9% of those patients who the EMS clinician said, yes, I have mechanical capture, they had no electrical capture whatsoever in the entire ECG waveform data. This was, I'll be honest, even more than we expected going into this study, and was quite a significant finding that this probably isn't a good assessment of whether or not the therapy has actually been successful. Next slide. And then you see here, you're starting to get, true electrical capture towards the left-hand side of the screen. And then what do you think is happening closer to the right-hand side? Next slide's going to tell us. That's what's happening. There's underlying VF in this patient. These patients are fundamentally unstable. You're pacing them. This case happened to have what looked like electrical capture, likely, and then they deteriorate. But in many cases, you actually have false capture in those phantom complexes obscuring what's happening underneath. So in this case, finally, clinicians identify that this is occurring, but truly, you can cup of coffee in a nice place, look back on this and go, what's happening? But remember, by the time that this is happening, it's probably during transport. So there's a lot of factors that are probably leading people to think this might even be artifact. Next slide.
Yeah, and I'll also say that, this is likely leading to significant delays to defibrillation. And we are in the process of publishing some of that data now. But there were multiple patients in this cohort that experienced a ventricular arrhythmia like VF while pacing was being performed. And then it was 5, 6, 7 minutes before anyone realized that the patient was in cardiac arrest because of that artifact on the monitor. And these patients went without any therapy for minutes, right? And of course, I think we can assume that that's not going to be good for outcomes.
All right, so our kind of three main takeaways are that it's an uncommon procedure associated with a high mortality rate. Sustained electrical capture is uncommon, and we don't seem to be recognizing it in the prehospital setting. And then delivered current, so higher max current, lower body weight, and lower pre-pacing heart rate were associated with sustained electrical capture.
So now we're going to circle back around and provide some clinical pearls based on this study, as well as some of the other studies that we've produced, examining the population of patients who receive transcutaneous pacing in the pre-hospital setting. I think one of the most important points is we need to pick the right patients. If you look at the demographics of the people who are actually getting this procedure, you see a lot of people in hypoxic respiratory failure. You see a lot of patients who are experiencing post-resuscitation shock, people with electrolyte abnormalities, right? These are people that are experiencing causes of bradycardia that are not necessarily caused by the heart itself. And so, again, in the example of hypoxic respiratory failure, someone who is becoming bradycardic and experiencing hemodynamic compromise because of hypoxia or asphyxia, they need their airway managed and they need oxygenation, right? They don't need their heart to be flogged with electricity. This may also be one of the reasons why we see that elevated initial heart rates prior to deployment of transcutaneous pacing, that's associated with bad outcomes. Because those patients who have a normal heart rate or are tachycardic initially and then brady down to require pacing, they may be more likely to be suffering from a reversible cause that's unrelated to kind of a primary cardiac bradycardia that's causing compromise. We've showed in this study that the higher you increase the current on your cardiac monitor, the delivered current is associated with increased odds of achieving sustained electrical capture. So don't be afraid to increase the current. We see a lot in this cohort. We see a lot of patients where the paramedics went up to 70 or 80 milliamps and then stopped. If you look at some of the other studies that have examined the thresholds for capture, almost always these thresholds are above 100 milliamps, right, in a large proportion of these patients. So don't be afraid to turn up the current. We've seen from our analysis of reporting mechanical capture versus actually having a chance to have mechanical capture, right? You need electrical capture to have mechanical capture. So we know that most of the reported, pulse palpation, those were false positives. So you need to use multiple methods to confirm capture. Pulse palpation isn't enough, right? We probably need to use kind of multimodal monitoring. Look at the pleth waveform from your pulse oximeter. Look at your end-tidal CO2. Look at your systolic blood pressure. Also make sure that you're palpating for a pulse, right? But be skeptical that you have capture and use multiple methods to assure yourself that the patient's heart is actually contracting. Point of care ultrasound is a tool that may have relevance here, right? If you can actually put the probe on the chest and see the heart beating with every paced complex, that's probably the gold standard if you have that tool available to you. Another thing that has been raised in conversations around these data and this procedure is, should we be using this procedure at all, right? We don't have good evidence that it's saving people, right, or benefiting patients. And there's some evidence that maybe it's obscuring the treatment of deadly ventricular arrhythmia. So we might even be harming patients. There might be a net harm that's produced by deploying this procedure in the pre-hospital setting. Maybe another strategy is better. So maybe going to an epinephrine infusion or an isoprotenolol infusion in the pre-hospital setting to increase heart rate is a better strategy. I would say also that if you are pacing a patient, so if you're using this in your system, if you've deployed the therapy, it's not over, right? And I think that we should be working to wean our patients off of the pacer, right? Whether that's starting an epi-drip, whether that's correcting reversible causes, administering atropine, we should be working to liberate our patients from these pacers so that we can observe ventricular fibrillation if it does occur. So maybe that's a strategy that deserves some consideration. Another question, just kind of anticipating it from the audience, does pad position matter? So there's one study out there that suggests that you can get capture more frequently and at lower currents with anterior posterior pad positioning with a Zoll monitor. That study used a Zoll monitor. There's another study that was recently published using a LifePacker Stryker monitor that suggests that that's not true and that patients who have anterolateral pacing have equivalent success, essentially. And so maybe it's device dependent, maybe it matters, maybe it doesn't. The verdict's still out. So Josh and Jude, I don't know if you have anything else to contribute to that. Happen to answer any questions. Looks like you're already taking care of some in the chat.
I think
Yeah, trying to.
I'll throw it to Josh. I think you probably want to talk about this because this is one of your favorite things with pulse palpation and violent muscle contractions. Everyone wants to know why is pulse palpation running us awry, running us aground?
Yeah, I try to address that a little bit in the chat. I think that, we know that in the asystolic unresponsive cardiac arrest patient, where it should be really easy to locate a pulse, that we struggle with it, whether we're expert paramedics, nurses, physicians, we've seen that across studies. Now imagine your patient has violent muscular contractions and they're hypoperfusing and they have an underlying rhythm that's not quite synced with the pacer, but they are actually having a heartbeat. I mean, it's really difficult. Otherwise, I would love to take others' questions.
Yeah, I have a couple. The first is I wanted to let me allow the people on the call to show their videos. Sorry, we did that on purpose. Okay, you can unmute and start video. Okay, Lou, you're good. All right, great presentation, and this, and mainly the overarching theme here is the amount of CQI, QA/QI that's required in our systems. So I think that this particular issue brings up, why QA, QI is so important. But the questions I have here are I have two, two questions. Gordon's question. So, do we have a problem of false capture recognition, or are we simply not turning up the amperage high enough? And should we be pushing in that direction? That's question number one. And then a third of the and if you look at other national data, it looks like it's a pretty common use case. Should we begin deprioritizing TCP post ROSC and instead prioritizing um, you know, medication management, push dose pressors, et cetera, in the post-arrest bradycardic patients? Those are my two questions.
I can start if you want. So the first question is this a recognition problem? I think recognition is part of the problem, but I suspect that some patients, even in an ideal scenario in the EP lab with the highest currents, POCUS, arterial line, if we had everything, we still wouldn't get capture on them. So I think it's both. It's
Okay.
sometimes pacing will not work, and we are often not recognizing when it's not working. So yes, some patients we probably aren't using enough current. Actually, I would say the vast majority of patients are not using enough current.
Okay,
We have
okay, so Josh, just to that point, and going to Gordon's point, why aren't we just maxing out? And to Ken's point, you have to sedate them. I get it, but why aren't we being more aggressive with the amperage?
I don't know. I think we could. I would have a very low threshold personally to go to max current. When you look at some of these original trials, that's what they did. They started at max current. If you look at some of the more recent studies in the EP lab, they're getting that threshold of capture on 130, 140 milliamps in the life packs and slightly lower in the Zols in a different study. But maybe we should have a minimum current. We should say everyone maybe you don't have to go to the max, but you better start at 140 or you better not stop at 140. So I think it's a very reasonable strategy. And when I talk to intensivists that are doing this in the ICU setting, they're often starting very high currents.
I do think it's related in that a lot of people are, you're trained to start at 80 and 80, and then in the
And
ACLS mega code, you always get.
I think I,
Oh, you're breaking up, Dr. Antevi.
go ahead, Tanner.
Okay, yeah, I was just going to say that. So I think it's related in that, right, we're trained to start at 80 and 80. In the mega code, you always get, right, the electrical capture at 90, right? And you know, as this is being done in the field, I think that people are turning it, to that setting, to 280, 290 milliamps, and then they think that they have electrical capture, so they don't believe that they need to go higher. So I don't necessarily think it's and maybe this is part of it, people being afraid to go higher, but they think that the currents that they're delivering are sufficient, right? I think that in that way, the lack of recognition of false electrical capture or the inability to identify electrical capture is what is leading to the subtherapeutic currents that we're observing. Although I'm sure, right, as the thorax twitches more, right, if the person expresses discomfort, that may be part of it. But then again, in our sample, the majority of these patients were GCS3, fully unresponsive. A lot were post-arrest, and so discomfort may not be playing as large a role as we think, right? And those
Yeah.
patients who are able to express discomfort are probably the ones who will do okay, right? And will end up having good outcomes.
Okay,
To
thank you. You mind just answering the second part, which is should we be deprioritizing TCP in post-ROSC patients? If you answered that, I was moving.
Yeah, I mean, so again, like we don't have any randomized, we don't have any comparative data to suggest that any specific strategy improves outcomes in this setting. So I will preface this by saying that this is my opinion. is I think that especially for patients who present with initially shockable rhythms, they have an elevated probability of shockable rearrest. And I think that there is certainly a mechanism for harm here in delayed recognition of shockable rearrest. I think that monitoring patients for rearrest is critical post-ROSC, right? This is something that can stop us from detecting that rearrest. And so I think that caution in the post-ROSC setting is warranted. I also think that from the perspective like post-ROSC shock is multifactorial, right? There's perhaps a large element that the cardiac stunning, there's compromised contractility where the inotropy, the inotropic support that epinephrine provides may be beneficial. You probably also have some element of vasoplegic shock. You get third spacing of fluid. Um, and so maybe that's better addressed by a fluid and vasopressor strategy than something like transcutaneous pacing that is really just driving the rate, right? It's not really augmenting your contractility. Um, and so again, although I don't have any data to suggest that one strategy is better than the other, based on the observational evidence that exists in theoretical harms, I do think that a drug first strategy is probably better.
Well, just real quick, after I read your guys' paper, I went into one of my agency's protocol where we had TCP at the very top of post-ROSC, and I lowered it to the bottom because I just think that I just think we have it wrong. So we have a lot of great questions. Kim asked, you guys are answering the question, but it's worthwhile just talking about it out loud. The use of ultrasound POCUS. Obviously, we've had POCUS on this webinar many times. Is this just another good reason for POCUS?
I, my opinion is I think it is the reason. If we look really closely at a lot of the POCUS and cardiac arrest literature, it's really tough to, I think, for some folks to even make the use case for it just because of potential interruptions. And then we've had debates about carotid, ultrasound versus getting a window on the chest and whatnot. I think that this could tip the scale in favor of POCUS, which could have multiple advantages. I really see POCUS as a gold standard for determining whether, electrical capture is present, right? Because, if you see mechanical capture, okay, I interpreted that rhythm right. But also, there might be patients we capture myocardium, we get some squeeze, but the myocardium's stunned from other factors, and you're actually not getting good forward flow. Knowing that is going to be, imperative. To the point about carotid ultrasound, because I know that was asked as well. I'm skeptical right now, just from anecdotal reports. The sternocleidomastoid tends to twitch with transcutaneous pacing, which serves as a confounding variable for manual carotid flow, let alone some, folks are looking at like, Doppler flow with the automated devices. I'm not sure that we have a good understanding of that right now. And I would be overjoyed to be proven wrong, and carotid windows would be, efficacious for capture determination.
Very good. Let me bring in a good friend, Dan Gerard. Dan, you wanna just go unmute yourself, just make your comment. Great comment.
Yeah, sorry about that. I was having a hard time finding the mute button. I'm a little bit older than some of the people here on the podcast. So, I mean, I remember when TCP first was rolled out and everybody put their arms around it. What a fantastic thing that we're going to be able to provide this out in the field. And you guys have done some stellar work. This is really going to drive us to look at protocol design, how we define success, and how it's going to improve outcomes at the end of the day, and really that's really what this is all about. And I'm glad that you put the idea, like there's a certain comfort in everybody's opinion about TCP, right? But the idea here is that we have to go to the point of discomfort where knowledge and efficacy and efficiency live. Great work, everybody. Thank you.
Thanks, Dan. And Lou, I want to come to you next, but let me ask Tanner, Josh, and Judah this question. You're gonna have people on this webinar who are gonna say, 300 patients. and Tanner started by saying, "Oh, not me, not my agency." How generalizable do you think this data is? And I'm kind of asking it rhetorically, but it is a small n at the end of the day. And do you think that your data here is generalizable to what's happening across this country and even further than that?
Yeah,
Yeah, so as far as the sample size, right? Across our study period, so we looked at four different EMS agencies. We looked at about 4 to 5 years of data for each agency. Um, we saw a range of about one patient treated with this therapy every 2 months to just over a patient a month treated. And so to do a larger study would take many more years, right? And I'm unsure of what the value of that would be, right? And this is something that we discussed a lot internally. Should we go back more years? Should we try to get more agencies involved, right? As we've had other people approach us with cases. I think that we have seen this at every agency that we've looked at. There have not been any outstanding, like across all agencies, although we didn't report it, across all agencies, the rate of capture was approximately equivalent and all were essentially single digit. Um, and so while there, and as future reports come out from other agencies, I think we're going to see the same pattern. And I think it's enough to say that this is a problem everywhere in the United States that is deploying transcutaneous pacing in the way that it currently is, included in the ACLS provider handbook. I would go as far to say we're probably, and maybe Josh can speak to this, we're seeing the same thing in the hospitals, whether it's in the emergency department, on the floor, in the ICU. Um, Electrical capture or false electrical capture is under recognized, and it is almost certainly not effective the majority of the time that it is deployed. Again, yeah, it is 300 patients. It's that might not be a lot when we're talking about something a disease process like cardiac arrest, but this is a procedure that is rarely indicated and rarely used, and even in the cases where it is used, I think that we would all agree that who have looked at this data that it is probably rarely appropriate. Um,
Yeah.
I'll,
so,
Well,
I'll
so yeah, Josh, I want you to make your comment because that's a great
yeah.
comment. Go ahead.
Yeah, I just want to add one quick thing. So when you think of like top performing cardiac arrest systems, I think you probably have a couple pre-hospital systems that come to mind. The one that comes to the top of my mind is Seattle King County, and they published data in abstract form. It's not in manuscript yet, showing that they also had high rates of false electrical capture. If the department that has about half their witnessed shockable cardiac arrests walk out of the hospital doesn't do pacing right with their very well structured, one of the best paramedic education programs in the country. I find it hard to believe that this is not present, not only in ambulances and houses and apartments, but also in the emergency departments and in the ICUs.
Yeah. Now, you guys are making some very good points here. Lou Steinberg is the king of QA, QI. He's written articles about this. He works tirelessly. The guy doesn't sleep. Lou, what say you? You've been around for a while. You've seen the TCP used at your agencies. You're now seeing this new paper. What are your thoughts?
So, one, I want to address what you said about Ross. We probably should be going to the pressers because we know that rearrest is more common than we thought, and we should be probably doing that anyway. So why not kill two birds with one stone? We're doing push press or epi drip. We're taking care of the rate. We're taking care of the blood pressure, and probably reducing the risk of rearrest. To Tanner, you kind of took a little of my thunder, but so we pace because we have bradycardia with poor perfusion, and atropine is not indicated or not effective. So electrical capture is just our first objective. Okay, mechanical capture comes next, but the real goal is improved perfusion. So the pulse bit, and I've said this before, I would guarantee the majority of those medics would check with carotid pulses. And we know that a high enough current everyone has a carotid pulse, whether they like it or not. So I came up last night, as a matter of fact, when you first put this out, that you really need to specify two means of verifying true mechanical capture, not just the pulse, but and I came up with a list of five. So pick two of the five. It's like Panera, pick two. So improved mental status, okay, would be one, not always achievable. A radial pulse with a rate that matches what you're pacing at. An improved end tidal, because the end tidal is going to be low with poor perfusion. It's going to be better with better perfusion. My co-host just came in. Pulse ox, if you have poor perfusion, you're probably not going to have a pulse ox reading. If you get a pulse ox back, probably. And finally, blood pressure. So two of the five, because just saying you had a pulse is probably not real mechanical capture. It's probably you want to have mechanical capture. And if you can bear with me for 1 second, because Josh mentioned maybe we shouldn't be pacing. So if you look at this, and I wish I could get rid, there we go, slideshow, the current slide. This is one I use for teaching consistently. So here is a woman who presented unconscious, blood pressure 70/40, and an idioventricular rhythm, okay? I use this slide to show what you're really doing with getting capture. So notice as you turn the current up, and this was starting 30, 40, 50, 60, got capture around 70. And then if you note on the next slide, I think we'd all agree that's effective electrical capture, at which point she woke up, her pressure came up to over 100, you knew you had capture. So it's a combination, but when you look at this, and especially if you go with this one, you're showing what you showed before, but with and without. So on the way to getting capture, and then actually getting capture, and then sustained capture. So taking that away.
You framed that, Lou. That's beautiful.
Yeah.
So Tanner and Josh, any comments on Lou's thoughts about maybe we should be enhancing our protocols, description of what capture really is. Obviously, we shouldn't be throwing TCP out completely. There are certain patients who do need it. Tanner, you mentioned it, pick the right patient. Um, so as we close, I'm going to give you both the final word here. You know, I almost feel like we're there's a three-legged stool and we just kind of took off one of the legs and TCP is kind of maybe not come crashing down, but should be deprioritized in what we do, not just in EMS but in the hospital. So give us your prediction of where TCP goes and any other thoughts you have coming up here with respect to this topic. Tanner, then Josh. Go ahead.
Yeah, so we plan to produce a little bit more data, some secondary analyses of that multi-center cohort. One of which, as I mentioned before, was quantifying for the patients who experience cardiac arrest while we're trying to pace them, what proportion are shockable rhythms, and then in terms of delays to defibrillation and delays to recognition of the rhythm, quantifying that, which might help highlight that danger. And then we're also going to be publishing some data looking at the ability of things like increases in end-tidal CO2, increases in systolic blood pressure, and even synchronization of the pacer rate and the pleth wave to see does that actually predict whether or not you have electrical capture. I'll say this is not published data. I will say none of those things are reliable in isolation. Like Josh said in the comments before, metrics like end-tidal CO2 are dependent on ventilation, perfusion, metabolic state. Many of these patients were just in cardiac arrest, so you see big spikes in end-tidal CO2 and then decreases even in the presence of capture, right? You know, blood pressure also it does not seem to be reliable. And one thing we've talked about with the King County folks is if you put a pulse ox on your finger or even a mannequin's finger and then you tap it rhythmically, you can get something that looks very much like a physiologic pleth wave. And when someone's being shocked and they're twitching, you can get a pleth wave when they don't have a pulse, right? And so, you know, in terms of the future of where this is going, I think we need better methods of determining whether or not this therapy is actually working. And we need to get there first, before we can actually, do some hypothetical trial that tells us whether or not it improves outcomes, right? And
So,
so,
so
yeah.
Tanner, so Tanner and Josh, I'm gonna come to you next. So, we have now a study that your study and even prior data that shows that TCP doesn't really have much value, right? Let's just kind of
Mhm.
overarching statement. Then we have a New England Journal randomized control trial showing that DSCD actually doubles survival. And we have the guidelines saying don't do DSCD, which we know works. And then we now we have this thing saying use TCP. How is it possible that you guys are the first people to expose that TCP? I mean, aren't where's everybody else? How come they're not clamoring that TCP has zero value? What are we missing here? Is it just that TCP has been used and it's like Dan said, it's been out there for quite a while and it's just hard to get rid of? Is that what's happening here?
I think that I think that fundamental teaching is driven by dogma
Hmm.
in this space. And when you are in paramedic classrooms or you're in, I remember I had the privilege of being at the EM residencies like EKG Education Day, and it was amazing how much misinformation about resuscitation that's guided by like just what somebody was taught before, meaning the best. But when that is set, it's so hard to change that. I'll say the most recent guidelines mention electrical capture and false electrical capture, which I think is a huge win. And Tanner, a lot of Tanner's work going to his PhD dissertation recently is working to change the guidelines. And so I think we can. Paramedics and EMTs, we're all three of us are EMS clinicians. And when we publish this, we're not doctors. We're working on it, but we're not there. And I think it is possible to make a dent. And I think these guidelines are it's like turning around an aircraft carrier in a narrow strait. It's really tough. It looks like you
So
want to say
Josh,
something. Yeah, go ahead.
yes, so Josh, will the guideline and the committee look at your paper and say this is good enough to make a change, or are they going to go and say we need the RCT, etc.? Like, what do you think it's going to take to change the guidelines here? Which is the big, that's really for me the overarching question, because your paper comes and no offense, it's a little blip on the radar.
Yeah.
We're all hearing it. We're all, our jaws are to the ground here, right? And now we're going to leave this, and unless somebody else takes the baton to say, unless an individual medical director or state or what have you really looks deeply into what they're doing, does their own CQI, evaluates their own data at their own agencies, nothing's going to change here. So how do we create? So Josh, this is your big question here: is how do we create the big change that's needed um, by going to the higher levels and saying, hey, look what we found. Please continue to evaluate whether TCP is valuable for what we do in the field.
Yeah, I think it's tough, but it requires advocacy, persistent advocacy at that level, being in those meetings. Those AHA guideline meetings are often written by people that are, I think, pretty distant to the out of hospital space. So getting more people that are in that space in those rooms is important, and something that Tanner and I talk about a lot is, we feel that we're part of the future of pre-hospital medicine and like advocacy there. So I think knocking down the door and trying to get there. I think the reality is AHA and ERC will not move their guidelines based on an observational study, but they might get close. I was surprised they mentioned our case series in the guidelines, and that was due to some pre-hospital involvement in that guideline room, and I know it was. But I think that I would love for someone to do an RCT comparing vasopressors to TCP. We had a pilot trial come out of Canada in like 2008, and they did a sample size calculation, and they couldn't detect a difference, but it was a pilot trial, so they couldn't determine whether a dopamine was better, and dopamine too, not epinephrine, dopamine
Mhm.
infusion to compared to pacing. I would love it if people did. The reality is, being around these academic centers and the emergency departments, which is honestly, I think, the best place to do it because it's super controlled, and it would be easy to do. A lot of them in the academic centers are going straight to isopril and transvenous pacing. And if that's the case, then okay, well, they don't feel like it's justified because they don't do it. But you know who does do it? people in the ambulance on the side of the road because they don't have that, or community rural access hospitals, that where that really happens. And I think that we need to move the needle, and in addition to being in those rooms, I think we need to change the way, we talk about the future of DCP. We need to change the way we think about it, right? I think we often teach it side by side with cardioversion, right? So cardioversion, you have a patient that's unstable, tachy. You don't go to meds, you go straight to shock, right? And I think we think of TCP the same way, even though technically it's usually they say go pharmacological first in the guidelines. So I think the way we frame it is a little wrong. I think it should be reserved for a highly selected group of patients. You should use high currents. You should be really skeptical, and you should confirm with a multimodal approach.
Yeah, that's a great way to end it. And I love what Joseph Zalkin said here, that could we be talking about masked efficacy all over again? So thank you guys for challenging the dogma. There's so much out there that we do today that we won't be doing in 10, 15, 20 years from now. And really got to give you guys a whole lot of credit for doing this. And don't say you're not doctors, because currently, folks, we want to give Tanner a huge congrats for passing his dissertation, challenging his dissertation. And now he got the PhD part of the doctor. He's now working on the MD part of the doctor. So then we can call him Doctor. So Tanner, you want to make a few final comments on how difficult that was, how much work you did, and just overall congrats, my friend.
Oh, thank you. Yeah, no, it was and I realized, in preparing it that I think every single publication that was part of that dissertation I'd previously presented on this webinar. So you heard it here first, literally.
Yes. Hey, well, there's not a week that goes by that someone doesn't text me that guy Tanner is a superstar. I'm like, yeah, I know he is. So congrats, Josh, Tanner. Thank you guys both. I know Judah had to drop, but many thousands of people will watch this. Hopefully, this webinar will change practice. I know it's already changed my own protocols. So thank you guys both. Keep doing what you're doing and keep leading this amazing profession into the future. And appreciate you guys very much. For those of you who are need CMEs, the number was put in the chat earlier, and the Dr. Pepe's webinar, the link is there. So it's 23089 for the CME. The link to join the webinar. We're going to be talking about some whole blood and the Swift trial on that one. So see you guys on the other side, and we'll see you all next time. Thank you, guys.
Thanks.
Bye, everyone.
All right. Thanks for coming, everyone. Appreciate
Hey,
it.
Tanner and Josh, one last thing I forgot to say. That patient I showed you, we got to the hospital and the doctor said, "Oh, let's take her off the pacer and try atropine." I'm like, no, 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 you don't want to. So she turned off the pacer, and obviously we know what happened there. The bottom line, though, is it was an unintentional beta blocker overdose
Mm.
and not carrying enough glucagon anymore. There really is not much of an alternative, and it
Mm.
did work quite well. So I'm not so sure that eliminating pacing in the future is really a viable. It just has to be used when appropriate and verified more appropriately, like you said, multiple methods, etc. So anyway, see you
Yeah,
on the other side.
I think for that reason, it'll be easier for the guidelines to be able to incorporate this sort of stuff. Like we're not asking anyone to buy anything. We're not asking anyone to do anything different. Like they can just put a throwaway line in there and be like, think about these other things before before you try. I mean, it's already at the bottom of the algorithm after meds, technically. So, they can't de-emphasize it much more.
Yeah, except like that one was medioventricular rhythm.
Mm,
Really, what meds are you going to give at that point?
right.
We kind of done away with isopril,
Yeah.
fortunately. Good line of isopril, the people who need it are probably too sick to get it. Um, but, I think part of it is teaching. I know when I do a simulation case, people have a bradycardia and they want to pace. It's like, well, wait a minute. His blood pressure is 100 over 60. His end tidal is good. Why are you pacing? Well, he's in a bradycardia. Well, no, we pace because they have poor perfusion, not just because the rate is slow. But too many people with that algorithm method, is like slow heart rate, got to fix it. Maybe not. Having an MI, maybe we don't want to give them atropine. Maybe we want to leave them where they're adequate. Cath lab might be a better fix.
Yeah. Um,
So,
Yeah, a lot of that's on us. Like, how do we train it? How do we simulate it? How do we, I mean, when I feel like when I had my TCP how to kind of simulation days, it was always like you turn it to 70 and magically you get capture and it's really easy. And they're just, and the way we simulate it needs to reflect real practice a little better.
and we shouldn't have not just anyone teaching it. Too often, oh, hey, you're on B shift, you're my buddy, you want to be a medic instructor, boom. And, being the best medic in the world doesn't mean you're the best instructor. So people just learn poorly because they're taught poorly and they don't understand. There's an Einstein saying, and it took me a while to warm up to it, but Nurse Gwynnie, because she makes sure she breaks everything down. So basically, and the Einstein thing is if you can't explain it simply, you don't understand it well enough. So I always caution the medics, you whip out these fancy terms and these fancy things, you understand it. When you put in your report and a lawyer is giving you a virtual colonoscopy on the stand, can you explain it simply enough to come across well? And in a lot of cases, the answer is no.
right.
So good job the other day,
Absolutely.
Tanner. You kind
Thank you.
of covered every bit of the last decade of resuscitation research and put it all together.
No, I appreciate you coming. I did see your name on there. I appreciate it.
Yeah, I watched till they put us in the waiting room, and then all of a sudden they ended the meeting, so I never got to see. But presumably you're a PhD by now.
That they passed me. Yeah, they.
It'd be hard not to.
Yeah.
You were pretty comprehensive.
Yeah. So no, it's I'm excited for the next chapter. So
Well,
I
now back
start.
to medical school, right?
Yep, I start my surgical rotation in a couple weeks here. So
Are you fourth year or third year?
so technically a third year, but I start residency next August. Because I'm in a program that they essentially cut most of the fourth year off. So like all your elective rotations and stuff, you just get to start your EM residency. So
And you're staying there for residency too?
yeah, yeah.
Okay, good.
Mhm.
Well, thanks, guys. I'll see you soon.
See you later.
Take care.
I'll see you this afternoon, Josh.
Thank you. Yeah, see y'all later.